All right, we'll get our next session started after the break. Again, I'm Kyle Dempsey, president and founder of the SSRA. Rory Daniel is working the back. She is vice president and executive director. Very excited to announce our keynote speaker, our chief medical advisor, and all-around great guy, Dr. Michael Levy. Thank you.
Thanks, everyone. I'm going to give a much more basic overview of superficial siderosis. I let the science go first, and now we'll just kind of touch on everything related to the disease that I think is important. Okay, so fundamentally, the problem is that there's iron deposits on the surface of the brain that are causing damage to the tissue underneath. So here's a schematic of what that looks like, and the real emphasis here is that the iron deposits are on the surface. That's why they call it superficial siderosis. It's not in the brain, it's on the brain. But even though it's on the brain, when the iron causes damage, it causes damage to that tissue right underneath it. It's very slowly progressive. As you heard Dr. Waring say, it takes about 10 years from the first event to cause even some symptoms, and then 10 more years to get a diagnosis. That's fairly typical. In our series, it took 17 years on average from the time when we know the event occurred to the first signs of hearing loss. So it's a very slow disease, and I'll explain why that is. Your brain actually has a pretty good capacity to buffer all this bleeding, but over time it becomes overwhelmed. And the most common symptoms, the first one I always hear is tinnitus, that hearing, that ringing in your ears, and then hearing loss, and then balance problems, and then kind of everything else all at once. The loss of smell, the bladder, all the other issues kind of come after that. So we make the diagnosis usually by MRI. That's what cinches it. And the reason is that if you just go out in the community for people who have hearing loss, 99.999% of them won't have superficial siderosis. That very, very rare case will. So it's not like everybody with hearing loss gets an MRI. But if they do, this is what we're looking for. On this is an MRI that is like, it's a cut through your head like this. And then you're looking at the brain in the back here, and all this gray stuff here is normal brain tissue. The iron is in black. And it's all this black stuff here, or that black blotch there. You could see black lining the inside there. And how do I know that this looks abnormal? It's because we look at MRIs every day, day in, day out, and we know what should be black and what should not be black. So you might say, well, what about all this black stuff? That black stuff is normal. That's the skull. And we can differentiate the skull from iron deposits because of the pattern recognition, what superficial siderosis looks like. And we've been trying to quantify this for years. You know, you could say, well, that looks like a whole bunch of black smudge, and then over the years it might get worse, and it's really hard to tell how much more black smudge there is on top of this. So we're trying to develop tools to do that, but that's one of the real challenges we have right now in research, is trying to quantify how much iron there is on the brain. I do want to emphasize another thing that Dr. Waring pointed out is that there are different types of superficial siderosis. And one type is called cortical. Sorry, how do we go back? Yeah. Cortical siderosis is when you have iron at the very top part of the brain, and only there. To get blood to the top of the brain, there's usually a problem at that very top part of the brain, usually a disease like amyloid angiopathy or previous neurosurgical procedure just right there. And it might cause a little bit of damage to that tissue and that part of the brain, but it's not going to lead to hearing loss and balance problems and everything else. That's a whole different thing. And this has become a really popular topic in the literature, in neurology, because I don't know if you are familiar with all the new Alzheimer's drugs that have been developed, and a lot of them cause cortical superficial siderosis. So I get a ton of these referrals from people who got Alzheimer's drugs, and that's not what you have. You do not have the cortical type. You have what Dr. Waring referred to as the classical or type 1 idiopathic infratentorial superficial siderosis. There's another type of siderosis that's just in one spot. So this is a cut of the brain, and there's a bunch of iron right there from some trauma, and it might cause damage in that little area, but it's not going to cause hearing loss and progression and all the other things that we're going to talk about. This is just a unique thing, and this is within the brain. You can see this is not on the surface of the brain, but within the brain. And again, there are many different problems in neurology, but this is not one of your problems. This is a different issue related to hemosiderosis. This is the problem you have. Idiopathic or type 1 or classical superficial siderosis, where the iron ends up on the brain tissue, and it almost always starts in the back of the brain. And I'll show you why it happens that way. But eventually, after it deposits in this back part of the brain called the cerebellum, eventually it spreads elsewhere. It just keeps spreading around the brain to different parts of the brain. I don't know that we have as many cases as Dr. Waring meant. Dr. Waring had a series of cases that they looked in the population and they found about 1 in every 2,000 people have some siderosis in the back of the brain. I don't know that we have that many cases. When we profiled our patients, we started with the symptoms first, not with the MRI. So maybe if we go out to everybody in the community and did MRIs on everyone like they did in the UK, we'd find a lot more. But the way that we're calculating the number of patients is we'll say, okay, how many people have ringing in the ears, hearing loss, and balance problems, and then on the MRI have superficial siderosis. So the disease plus the MRI. And that seems to be a lot rarer. So we calculated about 1 in a million or 1 in 2 million. So in total, about maybe 300 or 400 people in the US. Now, again, maybe there are more people who have the MRI findings if we really go out in the community and look. I get about 10 or maybe 15 new cases a year. The ratio of men to women is about the same. It's not really a disease that's segregated by any type of person. Anybody can get superficial siderosis if they have the right type of trauma or neurosurgical event that leads to it. And most of my patients are in their 50s and 60s, and I'm turning 50 this year, so I can't call it old. So it's everything 60 and older is now old, no longer in their 50s. But the reason that most of my patients are older is because it takes 10 to 15, 20 years before people come to my clinic after their traumatic event. And probably one of the most common things I hear is a bad car accident in their 20s and 30s, flying through the windshield. This is just so common. And then 20 years later, they have the hearing issues. And you go back in time and you put the pieces together. It's all from that trauma 20 years ago. But they're already in their 50s when they come to me. So that's the most common thing that I hear. And the types of trauma I hear is car accident, falling off a ladder, kicked by a bull. I mean, it's everything that you can imagine related to trauma in the head and in the back and in the neck. Okay, so why does the siderosis always start in the back of the brain? The reason is that the bleeding is almost always in the spinal column somewhere from your neck down to your belly button. That's usually where the bleeding occurs, and then the blood ends up in the spinal fluid, which circulates. So you make spinal fluid, you make it deep in the middle of your brain, it circulates all the way down and then back up. You make about 3 times the amount of spinal fluid you have at any time every day, so it circulates constantly. And if you have a bleed into the spinal fluid in your spine, then it's going to circulate up and end up just by gravity. When you lay down at night, it's going to end up in the back of the brain. I'll show you a picture of what the back of the brain looks like and why it tends to trap the blood products right there. But usually, I'd say about 70 to 90% of series have looked at where the bleeding occurs. It's somewhere in the spine. Here are all the reasons that you might bleed in the spine. Again, trauma, I think, is number 1. Tumors, neurosurgical procedures, and there are tons of if you go to the Massachusetts General Hospital right now, they're doing tons of neurosurgical procedures every day. Most cases don't bleed like this and end up as superficial siderosis. A few do, and we need to understand why those patients end up with superficial siderosis. Okay. All right, so iron is toxic to the brain. The reason iron is toxic to the brain is because it's an oxidative process. It causes damage to the lipid lining around the nerves. The iron comes from your red blood cells. Your red blood cells make heme, which is a protein that holds the iron, and then it circulates in your body. And when it gets to the lungs, the iron molecules help to hold the oxygen, and then when your blood gets to the tissues, the iron molecules release the oxygen, and that's how you get oxygen all around your body. So this heme iron thing is a really good product of your body, except when it leaks into the spinal fluid, because it doesn't have any purpose there. And in the spinal fluid, over about 2 or 3 days, the red blood cells will die, they'll break open, and all of that heme iron product will leak out. And heme and iron, they stick to each other, but not very tightly, so the iron gets free, and then the brain freaks out. The brain does not want free iron. Iron is very, very tightly regulated in your body. So the first thing that happens is that your brain cells make a protein that'll quench the iron, and then it'll take up the iron and try to metabolize it and send it back into circulation. So people bleed all the time in their heads. They have trauma, and we've evolved over millions of years to handle that kind of bleeding in our heads. So there is a system to handle blood in your spinal fluid, and it's fairly efficient. It's only when you overwhelm that ability over time, over bleeding over years and years and years and years, that then the brain can't handle it anymore. And instead of metabolizing the iron, it'll just send the ferritin and other proteins into your spinal fluid to quench it and then just leave it there, because there's no way for it to metabolize any more iron. And then that circulates around your brain and eventually deposits on your tissues and then causes damage to the tissue underneath over time. But you really do have a large capacity to handle all this iron for many, many years, and then you have the capacity to quench the iron over many years, and that's why it takes 20 years for the first symptom to show up. Here's the chemical reaction that the iron molecules undergo to cause free iron. And this is a schematic to show how your brain handles free iron. So you have the final product is called hemosiderin. When ferritin binds iron, it makes hemosiderin. And that is not able to escape the spinal fluid anymore, it just gets trapped. And every once in a while, the ferritin will let the iron go, and the iron causes the oxidative damage to the fatty tissue of the brain. So that's the fundamental problem. Here's kind of a gross picture, but this is the cerebellum, that back of the brain. This functions to control your coordinated movements, all your fine motor movements. Like you can imagine Michael Jordan's cerebellum is very, very well developed, right, to handle the basketball. It really just has motor function. It's all your coordination balance. And it has these, you see these lines here? These are very, very tiny folds. And when spinal fluid is circulating around in there, the iron gets trapped. It's all trapped inside of these tiny folds of the cerebellum. That's why the cerebellum is mostly affected. It's because there's so many places for iron to get trapped. And it looks black on MRI, but when you look at it in the operating room, it's got this rusty orange tinge to it. So that's what iron on the cerebellum looks like. Now, right next to the cerebellum is this tiny nerve. This is the nerve that handles all of your hearing and balance function going to your inner ears. Look how small it is compared to the rest of the brain. This nerve spends a lot of time in the spinal fluid. That's why it's particularly vulnerable. Not that many nerves spend as much time in the spinal fluid as that one does. And that's the nerve that goes to your ears. So when that gets coated in iron, it causes damage to the tissue underneath, and almost always the first symptom I hear is that ringing and then hearing loss. And it's because this nerve is so vulnerable to iron in the spinal fluid. Microscopically, if you could look at the tissue under a microscope, all we see is tissue loss. There should be lots of nerves here in the cerebellum. But if you have superficial siderosis, what happens is that the iron damage just causes nerve death. And then over time, as those nerves are lost, you try to compensate. So if one nerve that goes to your trunk to handle balance and things like that, if that's lost, then other nerves will try to take their place. And you could do vestibular rehab to strengthen those circuits. But if those nerves then get damaged, then you continue to progress over time. This is a cool iron stain that turns cells blue. What it looks like under the microscope is these cells that are trying their best to metabolize all that iron. They're just full of iron, just chock full of iron, and they just can't handle any more iron, so they make that ferritin, which then gets secreted into the spinal fluid. So the bleeding in superficial siderosis comes from the lining around the spinal cord in most cases. That's called the dura. And the dura is represented here in orange. It forms like an outer barrier that holds all that spinal fluid in. And it's a tough membrane. I remember dissecting this in a gross anatomy class in medical school. It's like leather. It's really, really strong. But if it bleeds, it doesn't heal very well. And then as a result, that scar tissue that's trying to keep the dura closed, it's just not as strong as the dura should be. And it keeps re-tearing and then re-bleeding. So Dr. Schivink's job is to try to fix a tear like this by using something really much stronger that can hold the tension in. When you get a CT myelogram, what you're doing is you're injecting the dye into the spinal fluid and you're seeing where it leaks out. And where it leaks out is usually where the damage is, and that's usually where the bleeding is coming from. And in some cases, the surgeon can go in there and maybe fix it. We'll hear from Dr. Schievink about those types of cases. In some cases, especially if your neurosurgeon says it's not a good idea, you don't want to go there and try to repair it because it might just be too risky to do that. We profiled all the different causes of superficial siderosis, and that's how I know that number one is head and back trauma. That accounts for the majority of cases that we see with superficial siderosis, but there are a number of other causes. There are some tumors that bleed. There are a few aneurysms that bleed over time, neurosurgical procedures. There are all kinds of things that can bleed. And then one of the interesting things is you could see they're in their 50s and 60s when they present, and it took anywhere between 10 and 25 years for those symptoms to start after the injury. So that's really what I want to emphasize. I do get a lot of cases where they'll say, I had a procedure 3 months ago, and now I have ringing in my ears and hearing loss. Almost certainly, the siderosis was there much longer, because it's really hard to imagine how 3 months of superficial siderosis can lead to this kind of damage. And in a lot of cases, if you look back at previous MRIs, you'll see that the superficial siderosis was there all along, it's just no one picked it out until the symptoms started, and then they blamed the last thing that happened. But it's usually something that happened a long time ago, rather than something more recent. The symptoms of superficial siderosis, I only have 81% here for hearing loss. I think it's closer to 95%. If you get people hearing tests, almost all of them will have some form of hearing loss. It's pretty rare that you'll find people without hearing as the first symptom. I do have some cases where someone got an MRI for a migraine headache or something else, and they have superficial siderosis and absolutely no symptoms. And that's a rare situation, but it's happened a few times. I've even had some cases where there's a ton of iron. And I'm thinking to myself, how do they not have any symptoms at all? That's pretty crazy. But that's one of the things we really need to figure out. Is it that this guy's ferritin is just so strong, it never lets the iron go and cause damage to the tissue underneath? Or is it that he can compensate? Maybe he does have some damage, but he's just compensating with other neurological circuits. That's something we need to figure out about superficial siderosis. I get this question a lot. Is it fatal? Do people die earlier? And the answer so far is we don't know, but my sense is that it doesn't seem to be fatal, but it does seem to be disabling. So it doesn't cause an early death, but it does cause a lot of problems with hearing and balance. And in older age, people do tend to rely on walkers and wheelchairs more than if they didn't have superficial siderosis. But as far as when you'll die, it's probably about the same time. I do have quite a few cases of people who had strokes as the cause of death. So if you think about the cause of death in most people, it's heart disease and cancer. That's kind of what we expect. But I do have an overrepresented number of cases who've died related to stroke, and maybe that's related to superficial siderosis. We just don't know. So you heard Dr. Waring talk about the different treatment options. I basically think about treatments of two approaches. One is stop the bleed. Go to the neurosurgeon, see if that's even possible. If it is, great. Then you have less blood to remove. If you can't, you can still try to remove the blood even as it continues to bleed. And so removing those blood products, we've been using deferriprone. And I'll show you in a minute what that looks like. First, there are other options. If Dr. Schievink and other surgeons don't feel like it's safe to do this surgery, you can maybe get a radiologist to insert a needle like this and inject a protein glue to try to seal that leak and allow the dura a chance to heal on its own. Sometimes that works, sometimes it doesn't. And then rarely something that we've tried is to do a blood patch where you inject blood at the bottom of the spine. It fills up the entire spinal column. It immobilizes the dura and gives it a chance to heal. Sometimes that works, most of the time it doesn't. I think the best approach so far has been surgery where they can really go in there, find the leak, find the bleed, clear out the debris, and really seal it tight. There's only one real good way to get all of that iron out of the brain, and that is this drug that it's called deferriprone. And it's a very simple molecule. It's an iron chelator. It just binds iron. It also weakly binds zinc and vitamin C, but really its job is just to get rid of iron from your body. It's approved in the United States to get rid of iron overload from things in the liver and in the heart and other places. It's not approved for superficial siderosis because we've never done the study. We've done these observational studies where we treat people and then we look back and say, okay, how well did it work? But the FDA doesn't accept those kinds of studies. They want a study with a control arm that gets no deferriprone and a group that does get deferriprone, and then to see which one does better. We haven't been able to fund that kind of trial yet. But the observational studies, I want to show you a couple of those studies. There are other drugs that chelate iron, but they don't get in the brain. Deferriprone is the only one that gets into the brain. So that's why we picked that one. We started with a very small group of patients back in 2009 or so, maybe 10 patients, and we only treated for 3 months, and we tried to just assess the safety, and it seemed to be safe. It wasn't catastrophic. There were a lot of reports when the drug first came out of immune issues and things like that. We just wanted to see if this drug was safe, and it was. So we proceeded with a second study. We recruited 38 people who were really kind enough to get all the blood tests that we asked and all the MRIs that we wanted. We tried to implement a standard approach for measuring iron deposits by MRI, and I'll show you what that looks like. And we did see most people were stabilized. clinically, but it was just a 2-year follow-up. So how do we know that maybe they were just going to be stable anyway for 2 years? It's a very slowly progressive condition anyway. So it's hard to say for sure, but we saw a lot of people who were stable, a couple of people who improved, and a few people who continue to progress. It was a 2-year study. Again, we were just observing people using deferoprone. And then we used this sort of AI tool to quantify the amount of iron. I don't know if this is a video, if we can play it, but this is an MRI here, and we maybe we can show it.
But it's the best way that we know how to do it.
You don't need to hear the volume. What's going on here is we use this tool to outline the parts of the brain that are affected in superficial siderosis.
But this is what needs to be done
And
in order to get
then there's this AI tool that then,
So essentially, we do this for every single slice.
here you can see how we're outlining the parts of the brain. We're telling the
Then
AI
we're gonna
tool
want to
what is the
get
brain
an
and what's
estimate.
not the brain.
Through
And then you have to do a few
software
more
program.
spots.
But so this is to be done.
And then
on
the
everyone.
computer kind of
So
figures it
for
out,
example,
and you kind of help it
user, get the desired
outline more parts of
outline.
the brain. And then you just ask the AI tool, how much black stuff is there before and after deferoprone? And then you standardize it to the white stuff, which is the spinal fluid that you're making on the inside of the brain, where there's usually no iron. And what we saw with deferoprone is,
Obviously, this is
let me
tedious.
see
but
if I
it's
can advance it. Here's an example, another example. Can you play this video, please? Now, as you look at it, you might say, well, it doesn't really look a lot different. Pay attention to the black stuff. You'll see the iron deposits here, here. This one is before deferoprone. This one is 2 years after deferoprone. You might say, well, it kind of looks the same. You know, as far as how much iron deposits, all this black stuff, it kind of looks the same. But if you look more closely, there are some improvements. And I'm going to try to, let's see, can you go back in the video? Can you go backwards? Yeah, stop right here. One more slide up. 2 up. Yeah, just hold on. I'll tell you when to stop. And stop on the next one. There. Okay. Yeah. All right, so you see, for example, on this one was done in 2022, and this one is done in 2025. And so if you look, for example, right here, right at the vermis, this is where most of the siderosis starts. And then you compare to that, you say, well, maybe there's a little bit less iron there. And then if you use that quantification tool, indeed, there's about 50% less iron right in that spot, right here. And then if you quantify how thick that line is compared to how thick that line is, there's a little bit of hemosiderin loss there as well. So that's a good outcome. But you can see how slow it is. This is 2 to 3 years of deferoprone, and that's all the difference that we see. But over time, it gets better and better. So we've been following patients now for about 10 years, and in many cases, it takes about 10 years to clear this iron out. So it takes a long time. Here's another example, a pre-deferoprone. You can see about how much iron there is, and then after deferoprone. So less black. Again, it's really hard to quantify these things, so we use these AI tools. We also asked patients how you're doing clinically. You could see most people were about the same, 2 improved and a few worsened. But overall, it seemed to stabilize people. So we think this was encouraging, at least for a trial to test it formally. There are things that we know that don't work. There's a copper chelator that's been around for a long time that also binds iron weakly, and it doesn't really work that well. We get calls from the insurance company all the time. They'll approve an iron chelator, but not deferoprone. They'll approve this one called XJade, which is the cheapest, but XJade doesn't get in the brain, so it's not going to do any good. And then people have tried spinal fluid shunts. So if you have bleeding, maybe if you just shunt the spinal fluid out, maybe you can reduce the amount of blood, but that doesn't seem to work very well. And then doing nothing doesn't work either. Once you start with symptoms, you're always going to progress. It's just going to take more time. Things that are untested that I'd also like to test is this new supplement that a lot of people are using called inositol hexaphosphate. Inositol is the building block of proteins. It's an antioxidant, so it blocks a lot of the damage from iron. The hexaphosphate part of this molecule is a weak iron chelator. It's available on Amazon. It's not even prescription. And it seems to be pretty harmless, so I do encourage that. Curcumin seems to help. Vitamin C might loosen the bonds between iron and ferritin, which might make it a little bit easier for deferriprone, or maybe faster for deferriprone to clear the brain. These are all untested. We'd really love to test this formally in clinical trials. So here are all the people who do all this work, including Dr. Kessler, who does all the MRI tools, which we love to use, and my group here, which I'd like to thank. And thank you, and I think we'll take questions as a panel in a little bit of time.
Thank you, Dr. Levy. We're going to keep moving along. I'm very excited. We have a surgeon here, Dr. Schievink. He's going to come up and speak next. Anytime you can get a surgeon, that is just outstanding. Thank you for taking the time. So I'm going to turn it over to him.
Thank you, Kyle. Thank you, Rory, for having me. Good morning, everyone. So I've been interested in this for, some time. This is when I was a resident back in the 1990s, and this is from a textbook, neurosurgery textbook, 6 volumes, like 3,500 pages, and there was only basically half a page on superficial siderosis. This is from Dr. Fishman, who was a neurologist at UC San Francisco, and what he said is that usually it's an obvious source of bleeding, like an aneurysm, vascular malformations, tumors. Didn't really mention the dura or anything related to the spine. This is when I was a fellow, and that's really, I think, the second patient I ever saw with superficial siderosis. And we worked that patient up with many, many angiograms, and then on one spine angiogram, we found this tiny little fistula that we thought was the cause of the superficial siderosis, but it probably even was, it was not the cause. As you can see there in that case report, the abstract, that we did do a CT myelogram, myelography on this patient, but it wasn't to look for a leak, it was to look for an abnormal tangle of blood vessels. And then because of this whole, belief in neurosurgery that superficial siderosis was caused by something you can see on an angiogram, something that has to do with the blood vessels. This is a patient I saw quite some time ago. As you can see, there's a lot of superficial siderosis. We actually thought that the upper part of the cerebellum had a little vascular tumor called a cavernous angioma. So we operated on this lady, and the pathologist said, yeah, we see a lot of vascular abnormality. We could call it a cavernous angioma. So that's how we treated that patient, by removing basically part of the cerebellum. And then this was another lady I saw in follow-up after we clipped an aneurysm, who also had superficial siderosis. And I thought, that must have been from when the aneurysm ruptured. This is what that aneurysm looked like at the time of the bleeding. Then later on, once I'd been working at Cedars for a few years, some of these studies came out. Dr. Kumar from the Mayo Clinic in Rochester, who unfortunately was not able to join us today, he really paved the way that a lot of the problems with superficial siderosis are caused by spinal fluid leaks in the spine. And then, of course, Dr. Levy, something amazing that you can give medication to treat superficial siderosis. But I had a lot of problems with calling what we see in people with CSF leaks superficial siderosis, because it was just in the cerebellum. So the articles that we wrote about this, we called it chronic cerebellar hemorrhage. And I did not call it superficial siderosis because it was not very widespread in the brain. And then this amazing paper came out by Professor Waring, and that totally changed our life in thinking about how to diagnose and treat patients with superficial siderosis, because he said there's this supratentorial part, the siderosis that's caused by amyloid angiopathy. That has nothing to do with this. But then there's this classical type, and that's always centered in the superior cerebellum, and most of it is caused by problems with your dura, right? Dura, the appropriate name is dura mater, which means tough mother. And indeed, it is like leather, unless, of course, if it's compromised. These dural defects that you find, right, almost always in the spine, and it can be traumatic, like Dr. Levy mentioned, after a bad car accident. You can kind of get an avulsion of the nerves coming out of your spinal cord. That can cause that. Or it can be spontaneous, right? So it's not from trauma, it's not from any type of neurosurgical procedure, but it's just a spontaneous leak. So we've seen 96 patients so far with infratentorial superficial siderosis, and there are very few patients who do not have an underlying problem with the dura. Now, of course, this is also very skewed because of the patients we get referred, but still, and only 2 out of those 96 patients were we never able to find a cause of their infratentorial superficial siderosis. So just to show you an example of, you want to play that video, perhaps? This is a gentleman who has this very obvious superficial siderosis. That's right, you don't really need to show it. Oh, there you go. And what happened to him in the past is that when he was in his 50s, still very young, he had this surgery. In the middle, you can see a CT scan of the upper part of the spine. You can see they put in like a big plate and a bunch of screws. And one of those screws had gone through the dura and caused a hole in the dura. And you can see there on the right, that's a picture that we took at the time of surgery. The surgery is done from the back. This is the spinal cord. This is a nerve going to his arm. And then there you can see the hole that the screw had gone through. This is another very common problem that we see in neurosurgery. As a matter of fact, 5% of people who have spine surgery get a spinal fluid leak. Most of the time that is repaired at the time of surgery, or it will just resolve over time, but not always. So these are pictures of these large collections of spinal fluid. This is all in the lower part of the spine. And these are people who have not been operated on. And we did this study where we looked at people I had seen at least 5 years prior and had decided not to operate on them. And then we had them come in for another MRI scan 5, 10, 15 years later. And 2 of those patients had developed superficial siderosis, one of them with symptoms, the other one had not gotten any symptoms yet. And both of them, so this picture on the left is an MRI scan, and then this portion in the middle is the spinal fluid space. And there's actually a leak within the bone of the spine. And same here, right? This is the normal spinal fluid space. And then here it's leaked into the bone. And I think, bone has bone marrow. It's very well vascularized. And I think those people might be at the highest risk of developing superficial siderosis. And then, of course, there's spontaneous spinal fluid leaks that causes something that we have named spontaneous intracranial hypotension. It's not that uncommon. Like every year, about 5 out of 100,000 people get this disorder. And the most common symptom is a headache. Almost always, at least in the beginning, it's what we call a orthostatic or positional headache, which means that the headache, when a person lies down, it's much alleviated. And when they get up, could be within a second, could be within 3-6 hours, their headache worsens. And there's a lot of other symptoms associated with these spontaneous leaks, and I'd like you to pay attention to, the same symptoms that you can get from superficial siderosis, the ringing in the ears, hearing loss, and also disequilibrium, right? So problem with balance and gait. We diagnose this now much more commonly than in the past because so many people with headaches now get a MRI scan. And what you can see is you can get bleeding on the brain. Oftentimes the patient will be told that, they must have hit their head, and they say, well, no, I didn't hit my head. And they're told, yeah, maybe you had something to drink, you don't remember that. But it's actually from the spinal fluid leak. You can get this, what's called enhancement of the dura. In Europe, they oftentimes call it the white line. Patients might be told that they have a tumor on the brain. They might get a biopsy, or they're told it's from meningitis. And then the other thing that's very common is the brain can fall down, and a person might be diagnosed with what's called a Chiari malformation, and they'll get surgery for the Chiari malformation. But that's not the problem. The problem is that there's not enough spinal fluid, the brain falls down, and it just looks like a Chiari malformation. So this was a gentleman who had an episode of very positional headaches. It went away within a month. He was never diagnosed with a spinal fluid leak. And then about 10 years later, he was found to have superficial siderosis. They did some tests. They did a very poor quality spine MRI. They did what's called a cisternogram, where they inject some radioactive material in the spinal fluid. Those tests were normal. And then I saw in him 15 years after the superficial siderosis was diagnosed. And you can see here on this much better quality spine MRI, this is looking from the side. This structure in the middle is your spinal cord. Right? This structure on top of is the cerebellum. And then right in front of the dura mater, here in the upper thoracic spine, you can see that there's a density, there's this long collection of spinal fluid that has leaked out. So there are many different types of spinal fluid leaks, and we have categorized them in these 4 types. There's type 1, that's when there's a tear of the dura. Type 2 is when there's a dural ectasia or cyst formation of the spine. And then type 3 is this somewhat newer type that we only discovered about 12 years ago. It's called a CSF venous fistula. This is what these leaks look like under the microscope, right? So this is at the time of surgery. Again, this is the spinal cord. That's the hole in the dura. And you can see that there's a very sharp piece of bone that has punctured the dura. And basically everybody who has these leaks in front of the spinal cord, the underlying cause is that there's either a disc that has degenerated or there's a little congenital piece of bone that has been rubbing against that dura. We do a test. You can see that here on the left. It's called a digital subtraction myelogram. A regular CT myelogram is not going to be helpful because it will not show you where the leak is coming from. You either do a dynamic CT myelogram or one of these digital subtraction myelograms, and then the CT scan shows the fluid that is leaked out. This is a little piece of bone, and this is with the ultrasound machine at the time of surgery. You can see the spinal cord here, and then there's that spiky little piece of bone. Then also some people, usually these are people in their 20s or 30s, they have a leak on the side of the spinal cord. We found that about 1 out of 5 of those people have a specific genetic mutation in the what's called the fibrillin 2 gene. For some reason, these people never develop superficial siderosis. So people with this type of leak do not have to worry about that. And then these are some pictures of simple cysts along the spine. It's actually very common, like 1 out of 3 out of 4 people might have 1 or 2 of those cysts, usually not as many as you can see there on the MRI scan. And then there's this usually congenital disorder that's called dural ectasia, and that's where the whole dura, especially in the lower spine, is exceedingly widened out, right? So this is supposed to be less than this here, but you can see this is much, much larger. It's like there's a giant sac hanging at the bottom of your spine. When you operate on that, sometimes this is the dura, and as you can see, this dura doesn't look very durable, right? It almost looks like parts of it are actually missing. And then there's this third type, the CSF venous fistula, and basically it's the type where there's a blood vessel that's sucking out spinal fluid from your spine. We looked at our experience a few years ago with spontaneous CSF leaks and superficial siderosis. And of the different things that we found is that if you have a leak in front of your spinal cord, you are at highest risk of getting superficial siderosis. But it's not just that type, right? So this is for everybody. So basically what that says, if you have a leak in your spine, a spontaneous leak, after 15 years of having that leak, there's about a 50% chance of having developed superficial siderosis. But how likely it is depends on the type. So when you have this type in front of the spinal cord, it's about 10% will get superficial siderosis. Dural ectasia, it's about 4%. The fistulas, 2.5%. Simple cysts, 1%. And then, like I said, the lateral leaks, those patients do not get superficial siderosis. But I think it's really important to realize that it's not just these leaks in front of the spinal cord. This is a patient that I'm going to see in a few weeks, and she has Marfan syndrome. And those are people who are very tall and lanky, and they can get problems with their heart and arteries in their body. And you can see there's very extensive superficial siderosis. Here's that white line around the brain, so we know that she's leaking spinal fluid. And there are quite a few possible causes of the superficial siderosis, right? There's this very dramatic dural ectasia. There are cysts. This is part of the dural ectasia in the lower part of the spine. But her doctors thought, no, this must be a leak in front of the spinal cord. So they had all these invasive tests done on her, and those type of leaks in front of the spinal cord, you can see them really well just on a regular MRI scan of the spine. So this was another example. So this was somebody who also was diagnosed with superficial siderosis some time ago, had a regular CT myelogram, was normal. But then when you do one of these more sophisticated myelograms, this is a digital subtraction myelogram. So this is the dye within the sac that's supposed to hold in the dye. There are like one or two of these little cysts. And then there's this blood vessel coming out, this cyst, that's draining all of the spinal fluid. So it's really important to realize that. These are some pictures of that I took at the time of surgery. And I think this demonstrates really well why do people with these leaks in front of the spinal cord, why are they at highest risk of getting superficial siderosis? It's because when you look through that hole in the dura, you can see that there are blood vessels, right? These are all blood vessels. It's called the epidural venous plexus, blood vessels there. And that's where this chronic bleeding is coming from. And because there's a leak that prevents the body from stopping the bleeding. Sometimes these holes can be pretty small. This was only about 1 millimeter. Sometimes it can be much more severe. This is a CT scan of somebody who has a leak, and here you see the piece of bone, right? This is the spinal cord. This is the piece of bone that's actually poking into the spinal cord. Here you can see it from the side. Sometimes it's a little bigger. Like here you can see that's kind of like a sharp little rock that's poking into the spinal cord. And that's kind of fun to remove that at the time of surgery, because you can, again, right, this is a spinal cord. Here you can see us taking out that calcified piece of disc, and it's fairly straightforward to remove that. I just show that to scare other surgeons, because usually neurosurgeons, they don't really like working around the spinal cord, and then when you have a sharp little knife, kind of makes them nervous. Over the last few years, there have been some good studies that come out. What is the success rate of doing surgery to fix these leaks in front of the spinal cord? And the results have been pretty good. Complication rate is fairly low. I've looked at the first 400 patients that I did this surgery for since 2011. And you can see here that the success rate of surgery is really high. It's about 96%, because we get an MRI scan usually within a day or two after surgery. And usually by that time already, you can see that the leak is completely resolved. Now, in people with superficial siderosis, because their leak has been so chronic, that can take a little longer. That can take 6 to 9 months to resolve. The risk of permanent weakness or numbness, usually in one or both lower extremities, is very low. The risk is very low, but it's not zero, right? So you always have to discuss that before surgery. These like is what I told you about. So 4%, 1 out of 25 people, will get a leak from the surgery to repair the leak. And this is the study that I mentioned earlier. This is from us at Cedars, and then Dr. Beck is a neurosurgeon in Germany. And sort of at around the same time, we published our results in people with superficial siderosis, and they were quite similar. So the period of time that people have had their leak before they're diagnosed with superficial siderosis was between 9.5 and 10.5 years. 10 to 12.5% of patients with a leak had superficial siderosis. Nobody was cured with a blood patch. And the reason is, if you've had a very chronic leak, even if the blood gets there or glue gets there, it doesn't really seal it because the body has walled off where that hole in the dura is. One thing that was different is that we reported that about 25% of our patients improved as far as their symptoms of superficial siderosis were concerned. And then in Dr. Beck's study, he said 75% improved. And I think the reason is that there's so much overlap between symptom of a leak and superficial siderosis that what I thought was a symptom of the leak itself, he thought might be the symptom of the superficial siderosis. The goal of surgery is just to progress any worsening of symptoms. We just started this year doing these surgeries through a little tube. It's called endoscopy. I'll show you a little video of that. I do these surgeries with one of my colleagues, Corey Walker. This is one of these digital subtraction myelograms. Here we drill off the access to the disc, right? So it's very easy, straightforward to remove the disc that has caused the leak. So with the endoscopic approach, you seal the leak from the outside, right? So not from the inside. You don't see the spinal cord. It all goes through the outside. This is somebody we just operated on a week ago. So you can see here that this is the collection of fluid in front of the spinal cord. This is some pictures during the surgery. And this, within 48 hours, that collection is gone. You can see that, the tube is very small. It's only about 8 or 9 millimeters. So, we don't know what the long-term efficacy is of this approach, but I think a lot of patients are going to be treated through the endoscope. This is an example of this dural ectasia. These are some pictures of what that can look like in different individuals. This is a test. It's called an MRI myelogram, but it's a totally non-invasive type of myelogram that just uses MRI scanning techniques. These are some other patients. And one of the reasons that neurosurgeons don't like operating on it is because the dura is so fragile that there's a really high risk of causing a leak if you're not careful. And even if you're careful, of course. This is a patient with neurofibromatosis type 1. You can see that there's a lot of dural ectasia. This is in the middle part of your spine. And then this is after we tried to fix the leak, but that had caused the leak, and there was a big bubble of spinal fluid underneath the skin. And this is when we make the incision to repair the leak that we caused. You also can see that spinal fluid is quite pretty. I always think it's the most attractive bodily fluid. It's really crystal clear. This is a picture of what we call the fistula. This is what it looks like at surgery, right? So there's like a little cyst, and then there's a blood vessel attached to that. And that blood vessel, it's what's sucking out the spinal fluid. And when we first started talking about these type of fistulas being the cause of superficial siderosis, nobody believed that because everybody thought that it's only one-way traffic, right? You can only go from your spinal fluid space into the blood space, but you actually also can have the reverse, and that depends on where you are in your respiratory cycle. These are some other examples of that. Sometimes those patients are born with a large vascular anomaly, and that's where they start leaking into. Sometimes it's not as obvious. Here, this gentleman just has some around the tongue and at the bottom of his feet. There are 3 good ways to treat these CSF venous fistulas. One is with injecting this fibrin glue. One is going through a vein in the groin and embolizing the blood vessels around that fistula. And then there's surgery. The surgery is very high cure rate, better than 99%. It's a very simple operation. So that's usually what we recommend. And then, we have talked a lot about the cerebellum in the brain, but you also can get superficial siderosis of the spinal cord. So this is a picture of the spinal cord. And that can be one of the reasons why there's so much trouble with equilibrium, right? It's not just the cerebellum. It can also be from the spinal cord itself, or if you get constant bleeding within the dural sac, you can get adhesions, and that also can be a cause of trouble walking. Some people get one of these 2 disorders, bibrachial amyotrophy or spinal cord herniation, in addition to the superficial siderosis. So bibrachial amyotrophy looks a lot like ALS, like Lou Gehrig's disease, so they lose muscle bulk and strength in their shoulder and upper extremities. Can you move your arms at all?
No, I can move my body and turn.
Well, this lady has lost complete function in her arms, and it's not from ALS, but it's from her spinal fluid leak. But she also has superficial siderosis, and we think that people who have superficial siderosis and this trouble with their upper extremities and shoulder, we think that the superficial siderosis around the spinal cord makes that more susceptible to developing this. So this also can be a very devastating type of problem from a chronic spinal fluid leak. That's just to show how, he used to be quite buff there. Not everybody has a loving spouse who will take that many pictures of you, though. And then these are all just a bunch of scans. But so the other thing that can happen when you have a chronic leak is that the spinal cord can get stuck in that hole, and then you become paralyzed in your lower extremities. So what we usually do when we have a patient with infratentorial superficial siderosis, we get this MR myelogram. If we see that there's spinal fluid outside of the dural sac, right, so it's usually a leak in front of the spinal cord, we get a digital subtraction myelogram. If we don't see fluid outside of the dural sac, it must be one of the CSF venous fistulas, and we do a digital subtraction myelogram in a different position for the patient. All right, so let me just quickly show these cases again. So this is somebody who had surgery thinking that she had a cavernous malformation. Then I read Professor Waring's report, and I'm like, okay, well, that doesn't make any sense. It must be from something else. Let's look at her scans again. This is the op note. It's not so interesting. Then when I looked at her old scan, you can see there at the very bottom, you can see that there's a little collection of spinal fluid in front of the spinal cord that's not supposed to be there. And then this is what we found at the time of surgery. And then this lady with the ruptured aneurysm, when I read Professor Waring's report, I'm like, okay, that cannot be from a one-time bleeding event. So we brought her back as well. And I showed that earlier. And then on her MRI myelogram, we found that she has these 2 large cysts in the lower thoracic spine. This is on the CT scan after the myelogram. So she went to surgery, and I clipped those 2 cysts. This is from an editorial that I wrote a couple of years ago. And I usually end these by saying to neurosurgeons, right, think dura, not vascular. But I think everybody in this room knows that already. All right, thank you very much.
Thank you very much. I just can't believe there's people with that talent on this planet. Our next speaker is Dr. Haddad, and he's going to be talking about some of the other things that people with superficial siderosis do. Thank you, Dr. Haddad. I know I will be listening to this one very closely.
Well, you should have listened to the rest. Anyway, thank you so much. I'm not a surgeon, I'm not a neurologist, I'm a hematologist, oncologist, and my only relationship to neurology is neuro-oncology. So I'll be talking about the medical aspect of managing the chelation. So this is just a disclosure. The views expressed here is not representative of any of my employers, and these are only mine. So to recap, as you've already heard, the bottom line is you have an issue of a bleed. And the bleed there in the form of red blood cells, after a while the blood cell sits there, degenerate, and it releases the heme molecule that Dr. Levy briefly talked about. The heme is made of 4 proteins that actually capture 1 molecule of iron in the center. And after a while, when it disintegrates, those ions actually get released. The good news is we are created with a lot of ways of handling iron, and some of them is a storage, a molecule called ferritin. So ferritin comes there from microglia or oligodendrocyte, and sometimes we have also in the neurons some deposits of ferritin, and it actually naturally chelates the iron. And the problematic one is the iron 2, or the ferrous molecule, because it's very highly reactive. So it gets there, gets captured by the ferritin, and it supposedly gets stored away. But however, as you heard with the continuous bleed, it overwhelms the system. So when the system gets overwhelmed, actually the capacity of the ferritin gets run over by the excess iron of the ferrous type that is very reactive and very, very toxic to the tissues. And that's when you get a lot of the aggregates and the ferritin overwhelmed and run over, and you get the hemosiderin that develops there, which is a degraded form of storage proteins and aggregates of storage proteins, among other molecules. And you get, unfortunately, the problems with neurotoxicity and neurodegenerative conditions. So the role of iron chelation in superficial siderosis is mainly we're trying to remove the excess iron from the CNS. And the goal is to slow or hopefully halt the progression of the neurological decline. If you see on the right, this is a diagram of some of the mechanisms of some of the 3 major drugs that we have in the US, and they are the chelators. The ferroprone, as you can tell, they actually act differently on the molecules. The ferroprone technically actually acts directly on the free iron, while the frizozox is the one that actually acts on the free iron, but at the same time it has another mechanism where it upgrades the transcription of hepcidin, which is a blocker of the protein transport, which means it will stop the iron from moving further in between cells. And then the furoxamine, the original iron chelator, again, it is a molecule that will act on the free iron along with the iron that is chelated by ferritin. So they have different mechanisms. So these are the 3 drugs that we have in the US, and you can tell here from this table, I hope that some people can read it from afar, but bottom line is they're different formulations. Deferoxamine is usually sub-Q and IV is an injectable drug. Deferoxamine is the oral one, and the one that Dr. Levy referred to in jokingly about the third-party payers. XJade is the actually marketing name. It's an oral formulation, and so is the deferoprone. But they actually, not only they have different mechanism of actions, although most of them are mainly similar in one way or another, but they are dosed differently and they are excreted differently. For example, deferoprone and deferoxamine mainly is the urinary route where we get rid of the drug, while the deferoxamine is the fecal route. They are also, they are more efficacious based on where the iron overload happens, and you can tell that deferoprone is actually beating them when it comes to CNS. Why? Because it can cross the intact blood-brain barrier, and stress on the intact because all of them can cross the blood-brain barrier if it is disrupted. So, and you can tell that the other ones actually are better when it comes to liver overload of iron and cardiac. Deferoprone seems to do much better. Also, side effects profile are completely different. So remember, it's very important if somebody is Googling iron chelators. If you're Googling the whole term altogether, you're going to get the side effects of all of them mixed, but not everyone of them have the same profile. For example, deferoxamine has the ophthalmologic, audiologic toxicity, as well as other issues with pulmonary toxicity among neurological toxicities too. While deferoprone, as you will hear in a little bit more details, it has the major dreadful side effects, which is neutropenia, and the most severe form of it is granulocytosis. It still has the GI upset and the liver toxicity, as well as arthralgia and zinc deficiency. Unfortunately for superficial sclerosis, none of them are approved for that indication at all. All of them are approved for situations where you have transfusion-related iron overload, the 3 of them, and the one in the middle is the one also that is approved for chronic iron overload from non-transfusion dependent thalassemia. So as you can tell, those Siderosis is not there for the indication. So whenever we're using these drugs, we're using them as off-label in this disease. So this is your famous deferoprone or Feriprox. It's an oral iron chelator. It's approved for transfusion-related iron overload and investigated off-label for superficial siderosis. So the mechanism of action, it actually binds the iron molecule and forms, it takes 3 to 1 molecules to bind one iron reactive molecule. It has lower affinity, as Dr. Levy mentioned, to other minerals, and the reason why we should know about that is how to follow these patients that are on chronic use of these binders. Copper, aluminum, and zinc. The most common one is zinc toxicity that you need to or depletion that you need to follow when you are on deferoprone. It crossed gladly, and that's why we're using it in superficial siderosis. It crossed the intact, normal blood-brain barrier, which is a key advantage in CNS iron issues. So what are the pharmacokinetics of this drug? It's absorbed rapidly as an oral formulation, and it is protein-bound less than 10%, which makes it very available in the circulation after you swallow it. The metabolism primarily is through the UGT1A6, and what happens, it actually transforms the molecule to a metabolite that doesn't function anymore, so that's how we get rid of it, and then we excrete it in the urine. The half-life of this medication is only 2 hours, which gives you an idea when it comes out of the system. Multiply it by 5, and you can tell that in 10 hours you should not be having much significant traces left in the system. Time to peak absorption is 1 to 2 hours after you ingest it, and the excretion is 75 to 90%, primarily through the urinary tract. So what's the rationale for use in superficial siderosis? As you can tell, it's an iron accumulation disease, and deferoprone crosses the blood-brain barrier, and it reduces the iron burden. And it has potential for neuroprotection and symptom stabilization, and it has been shown in some of the preclinical and clinical studies of neurodegenerative disease like Parkinson's disease and Friedreich's ataxia that demonstrate that its ability to reduce the brain iron. So please pay attention to this language, decreases the brain iron. It doesn't talk about clinical outcomes, whether it improves it or not, which is another very major issue for the patient is, yeah, fine, you can show me that it decreases the iron level, but does it help me, which is the most important thing for a patient. But at least these are the things that we can base ourselves on mechanistically to say that, hey, it's a good idea to try deferoprone, apart from Dr. Levy's study. The controversies in iron binding is the following. When do we start deferoprone? Is it upon clinical symptoms? Do we have to wait for the clinical symptoms to arise to go ahead and use it? But if we do, are we missing something? Are we at a point where the damage is done and whatever is done, we cannot reverse it? Is it something that we need to wait until then? We don't know. Is it too late then? We don't know either. So how to dose deferoprone is another issue. And the issue the major one is, if we are giving deferoprone, we are chelating iron. But remember, the disease, superficial siderosis, is a compartmentalized disease. It's not a systemic disease. So are we deprived the rest of the organs from iron, which is another important thing because it can create other issues like iron deficiency anemia. You can deprive some of the enzymes of the iron that are very vital in the metabolism. So this is something to keep in mind. And the other issue is, how do we dose it? Should we look at the enzymes and makeup of every individual? Should we incorporate pharmacogenomics there to see, are you one of the people that actually metabolize the drug very fast, or are you a slow metabolizer where the drug lingers on and you can get more exposure to the drug, therefore more side effects from the drug? So these are very important issues. What is the optimal dosing regimen that we are going to use there that helps systemic and superficial siderosis and avoid the systemic side effects? So these are a lot of things that we still don't know. What about the duration of the treatment? So should we follow the CNS ferritin adapted approach? How long should we continue? Until symptoms, indefinitely, until we get an MRI that shows some improvement, until the patient's quality of life improves and tells us, like, I'm fine. Should we continue? Should we stop? Should we maintain? So these are all questions when I was introduced to superficial siderosis by the Daniels. These are all the things that I sat down for hours in clinic talking to Rory and Mr. Daniels about this issue, and neither one of us had good answers. So we kind of sat down and have the patient have an opinion and have come to a very comprehensive discussion to see when do we stop and when do we continue. So what about the determination of response for these medications? Again, we don't know. How do we determine the response? Is it by biological markers like CNS ferritin? Is it by imaging like the MRI, the T2 star MRI? What are the clinical criteria that we're going to follow to say, you know what, the patient is responding? Is it by just having the patient tell me my quality of life is better, which is a very important thing, absolutely very, very important. When do we stop treatment? again, it's something that we have to sit there and have a patient-physician discussion about, is it still helping you? Are you plateauing? What is it doing for you? Is the side effects worse than the disease itself? Because for some patients, they do have a lot of side effects from the medication. So it is something that you have to sit down and have the discussion. Again, is there any clinical criteria that will help us stop the treatment? And the other thing is, we've heard a lot about from our surgeon here in the crowd about certain high-risk procedures. We heard from Dr. Levy that the disease doesn't happen overnight. So we have a long period from the insult to the CNS compartment up till the disease appears and starts progressing. So is there any role for early detection and mitigation if we know that there's a high-risk procedure that will cause this? Should we be doing an MRI like in 5, 7, 10 years for those high procedures to catch it early on? But again, the question is, can we do anything to reverse it? Are these medications worth talking about to intervene at that point in time? So these are a lot of questions that we really don't have the answer to. But it's the disease is very, very provocative in its mechanism and etiology. So how do we monitor? When we start someone, we go ahead and start on deferoprone, how do we monitor the blood parameters? So on baseline labs, we usually get a CBC with differential up front and an iron panel with zinc as a baseline. We get a liver function test as well as renal function test, and these are bundled together in the CMP in the US. And it's very important for young ladies that are of reproductive age to have a pregnancy test definitely before we start the issue. The question is, should we get a CNS ferritin level as a baseline? And usually I'll leave it up to the neurologist at that point in time. And after we start the treatment, the ongoing monitoring will be, we definitely do weekly CBCs for 6 months straight. If everything is fine, and this is if and only if everything is fine, we go to every 2 weeks for the next 6 months. Very important the first year, very important, and you'll know why this is important in a second after we go to the following slides. The iron panel, we usually get it every 1 to 2 months. Liver and renal panel, usually monthly, and zinc regularly. There is no guideline about the zinc, but it's nice to say every few quarterly or so get the zinc to see if it's trending down or not or staying stable. And again, what's the role of CNS ferritin in ongoing monitoring? Again, this is something I'll leave usually to the neurologist to document whether in the CNS compartment there is a reduction in the CNS ferritin. So the key risk and warning signs, and this is the key side effects that I'm going to briefly go over. GI upset actually happens very frequently. It's one of the most common things where you get anywhere between mild and significant symptoms. And actually, it's the most common side effects that will interrupt the treatment and will stop eventually the treatment because the patient cannot tolerate the drug. So what we usually do is either we temporarily stop it, sometimes we dose reduce and try that, or sometimes we try liquid formulations to see if that will help or not. So 5% of the patients discontinue the drug permanently because of simply not able to tolerate the GI upset. We're not talking about the serious side effects yet. Another one that is common is arthropathy. And so, again, we do the same thing. Either we give a drug holiday or we might actually use symptomatic management for pain control with arthropathy is aches and pains in the joints. Zinc deficiency, it's easy. Usually it's most common in diabetics, and we usually replace the zinc. It's an easy fix there. Things that can be a little bit scary is the elevated liver function test. But We continue to usually monitor them as long as they're not above twice the upper limit of that particular lab. And if it happens to go over there, that's when we have to stop the medication until the liver function tests recover and then resume at a lower dose. The last two are the ones that are usually the scary part with deferriprone, is neutropenia and agranulocytosis. Usually neutropenia happens between 5 and 8%, and all you need to do is hold the drug and then reduce the dose and hope that it recovers fast. Neutropenia is anything that is lower than 1,500 neutrophils, absolute neutrophil count. It's a part of your total white count. So when you get your CBC, you have the WBCs, and then I'll tell my patient, the WBCs is like your Congress. It's made up of many parties. So you have the neutrophils, which are the majority, and by the way, they are ordained to be majority from the time you were born. They are always going to be, it's not a democracy in the blood. There's no democracy. That's why it's red. Therefore, neutrophils are always your majority. The second majority will be your lymphocytes, and you have monocytes and eosinophils and basophils. So that's why when you look at your CBC, we're not looking at the total count. We're looking at the absolute neutrophil count, and this is what counts because this is the scarier one. So if it goes below 1,500, then we actually hold, we let it recover, and we re-challenge. If it goes again, then we reduce the dose. What we do not like is we hold and it goes down, and we check it again, it goes down, and we check it again, it goes down. And once it hits less than 500, we are in panic mode at this point in time, because at this point in time we need to have GCSF on board, which is granulocyte stimulating factor to bump up. It's like a growth factor to bump up your white count and salvage that effect from the drug. So the risk of serious infection starts happening when it hits 500, more so when it hits 200, and that's really scary at that point in time. So you have to be on prophylactic antibiotics and growth factors. So the agranulocytosis, it usually occurs in your first, and this is a slide to show you when you look at the blood smear, usually there are multiples of this around, all over. But it's in one field, you can only see one white blood cell or neutrophil. So usually it happens in the first year. Most commonly, it happens in the first year. Therefore, that's why in your first year, and if you're on deferriprone, you are on blood sticks weekly for 6 months, every 2 weeks for the next 6 months. However, if your neutrophil drops a little bit, I will not let you go every 2 weeks. You're going to go back to weekly. So it's very important to be very careful about this, because this, although it is reversible most of the time, people can die from a serious infection that you cannot control with just antibiotics. So it's very important to have a grip on this side effect and manage it early and carefully and effectively. And the management includes drug discontinuation, as I said, and supportive care. Now, if this happens, do not re-challenge the patient for the physicians that are, whoever is attending remotely, because it will happen again. So when that happens, sorry, deferriprone is not your drug. We have to find you something else. It's not worth your life. As Dr. Levy said, majority of superficial siderosis patients may live the normal lifespan of the general population, though with disabilities. However, it's not worth your time to kill you earlier from a drug that was supposed to help you. So the dosing strategies, as I mentioned earlier, and you heard, is the reason we do those 5 days on, 2 days off strategy is to reduce the systemic exposure so that we will give you some time for the system to absorb enough iron back into the system and replenish the circulatory compartment and the non-CNS Remember, the CNS always likes to live in exclusion and thinks itself out of the body because of the blood-brain barrier. So the rest of the body is always in the same compartment, and it needs its iron. So it helps also preserve your hemoglobin and not cause significant serious anemia. And it's better lung tolerability. It seems that it's better tolerated that way. However, if you start still having issues with nausea and arthralgias, you might think about splitting the dose or taking the majority of the dose just before going to bed so that the side effects happen while you're sleeping, majority of the time while you're sleeping, and then hopefully by the morning the side effects have been abated before you get the other dose. It is good in theory. It works in some patients. It doesn't work in some other patients. So what about patient education and support? Make sure that you educate the patient about the process. In oncology, we know that our patients hear the only positives of what we say and ignores all the negatives that we say. And it's human nature. We like to know that there is hope, and hopefully we continue to have hope for every single human being. But again, it is important to let them know that, yes, we're trying to help you, but also you need to help yourself and help us too through the process. So very important compliance with those weekly tests up front, because we don't want you to disappear on us for a month and then you come back and your neutrophils are already bottomed out, or that is if you don't get a call from another emergency room or another ICU that your patient has been admitted somewhere else because he came in with fever, sepsis, and he's in the ICU. So very important to educate and very important to impress on then compliance with those test monitoring. Report symptoms early. If you start having a lot of fatigue, shortness of breath, dizzy spells, please let us know. You're probably anemic. If you start having a lot of bruising, you might have some issues with your liver and the coagulopathy there because the liver doesn't function very well. So please let us know what your symptoms are and continue this open dialogue and back and forth information between you and your physician that is taking care of you. Coordinate with neurology, hematology, and primary care. These are your major key players in your care, so please have an open channel all the time and a candid channel with them all the time. And finally, understand the rationale for the regimen and set realistic expectation. Remember, this is not a curative procedure. We are trying to halt the disease and maybe improve on the symptoms that you have. So it is important to always make sure that we have realistic expectation of what we're doing. So I added those two, although they are not part of the management, just to tell you that deferriprone is not the end of the world. Things are going on in the chelation, iron chelation arena. You have multiple drugs. You have the DFAs. They are oral intravenous, and they have the ability to bind iron that is induced, iron-induced ferroptosis, so it shuts down this process. You have the CN-128, which has a much improved scavenging ability and safety profile compared to deferriprone. In transfusion-related, remember, again, it's not in this data is not in superficial siderosis. These are all in transfusion-related iron overload. You have CM1, which is an oral active chelator with high selectivity for iron-3, which means it can even snatch the iron out of the ferritin molecules and the hemosiderin aggregates, and has a favorable pharmacokinetics and low toxicity in preclinical studies. TLCA is a nanochelator with nanotechnology. It demonstrates superior iron reduction and lower toxicity compared to deferoxamine in animal models. And you have the hydroxyzones, and you have the phytochelators. And these are novel iron chelators that were tested in neurodegenerative disorders. You have the PB434 and M30 and the SIHs. And the last one is the novel one, hydroxypyrazone, one derivative that showed have neuroprotective effects in vitro compared to deferapron. So there are molecules that are coming on board for chelation, and hopefully you can get your hands on them, get hold of them, and maybe down the line, Dr. Levy or other neurologists can actually convince the pharma companies to use them, or at least try an exploratory cohort with one of them. The questions, I was told, they are to the panel, and thank you for your attention and for your time.
Let's take a quick 10-minute break, and then we got patient focus next. It's going to even be better. I can't believe it.